the internet. We're live over here. We're live over here. Give it a couple of minutes. Just give it a minute, 30 seconds to do its thing. Wait for someone to come on, if you would. And then it'll be really nice.
Well, all right. And good morning, CNY Nation. I'm Dr. Randy Fink from CNY Fertility in Colorado Springs and the evolving CNY Fertility at the Miami Center of Excellence in Florida. If you're used to watching conversations with Kiltz and Fink on Thursday afternoons, you'll see me there, customarily not here on Dr. Kiltz's Sunday house call, but we had a very special weekend this weekend, and we'll tell you about that. And before handing it over to the boss here, also joining us is Dr. Faruqi, the incredible powerhouse that he is from CNY Fertility in Montreal and also in Syracuse. And why, might you ask, are such a dream team all together in one place today in upstate New York near Syracuse? Well, Dr. Faruqi, tell us why we were all together.
Wasn't it just to have a party?
That just to have a party, but why do we have a party?
We're here to sort of share and grow, and we're all learning together.
Well, wait a minute, hold on.
And Dr. Fink is joined the team, doing an amazing job at retrievals and transfers, and we're really, really, really excited about that.
But it was Dr. Kiltz's birthday.
Oh, yeah.
And it was Dr. Faruqi's birthday.
Hey, but that was the party.
There we go. So yeah, that was all the good reasons. So happy that we're able to have you with us on a beautiful Sunday morning, wherever you're joining us from, CNY Nation. So let's see if we can't take some questions and talk about family building, talk about fertility, talk about things that are on your minds.
All right. So hello to the Facebook, YouTube, and Instagram. We're really going to be answering questions and really sharing thoughts and ideas, improving your fertility journey. If you're already a CNY Fertility client patient, thank you for joining us. If you're new to our story, we're really integrating an Eastern Western approach, how we can bring faith and food and Western medicine to improving your fertility journey in so many ways, helping so many naturally conceive. But if it's not natural, through IUI or IVF or reproductive immunology. And we are reproductive immunology experts. We are here to share with you ways of improving your journey. So hello to Mel, let's see, Agir 007, Hazel, the IVF nurse, hello.
Special shout out to Donna from our global travel team.
Hey, Donna.
Hi, Donna.
Nice to see you. And for the folks who aren't familiar, we see patients from all over the world, not just the great nation of ours, but it's the global travel team that makes that magic happen wherever you are. I saw Nikki called us gentlemen, so clearly she doesn't know us very well.
No.
Right? Thanks, Nikki. Good to see you.
And a little, so if you go to Amazon, you can get our family building guide, our keto lifestyle, the fertile secret, the daily intentions, inspiration. You'll find so much there. Or go to our website at CNY Fertility and learn more. Wherever you're going for your fertility journey, you can bring some things to your physicians, your practitioners that they might not know about, and they're open and willing to do something different than they've been doing. And that's the one thing I've learned, that doing different will bring us to a new level. All right, let's hit. So confused, Def 81. You want to take that, Randy? Can you see it here over here on Instagram?
Well, let's see. We're confused about the timing on the second trigger shot. Yeah, so daylight savings may have thrown a little curveball into that. So, Dr. Faruqi, trigger shot happens when?
12 hours, and it doesn't matter what time it is. It's 12 hours.
So the 34 to 36 hours before retrieval is that first shot.
Yeah.
No, this is good.
Yeah.
And then the second shot is given 12 hours after that.
Yeah.
But with this daylight savings times, it's 1 hour. It's not going to matter at all because it's a window of retrieval. So don't be too confused on it. If it retrieved an hour later or an hour earlier, it really doesn't matter. Now, if it's 24 hours earlier or later, then that may be an issue. So we have to be cognizant of that. And let's take
Amanda has a great question there as it pertains to losing weight on with kiltz keto and on the baby diet. Yeah, there you go. You are already thin. You're losing about 1 pound a day. And you have concern about whether your body can support pregnancy without that extra body fat. This is a good one. And how often can you eat the ice cream? How often can you not eat the ice cream, I think is really the question. But, Dr. Kiltz, that's right up your alley.
Well, the whole idea of fasting is to reduce the contents in the belly, which puts sugar into the bloodstream and damage the body more than anything. But if you're losing weight on that one meal, go to 2, 1 meal, 1 snack, but add the fat. That's really the critical part to this. So you're either not eating enough calories or you're doing too much exercise. So I always say, add the fat, which is basically Kiltz's keto ice cream. It's high fat, it's cream, egg, a little bit of white sugar. In my opinion, is sugar cane. It's natural, it's healthy when you intermittently use it. But if you're feeding the belly all the time, it's not good. But if you're losing weight and you shouldn't be, then up the fat, twice the calories, or add that one snack to the diet. I think it's really critical. Check out our books on Amazon, have a lot of helpful information.
And actually, you don't need a lot of extra calories when you're pregnant. It doesn't take much. A glass of milk probably is enough to give you the extra calories.
Cream.
Well,
whole milk, but cream.
No skim milk, please.
But the cream is critical. But when you get pregnant, the Kiltz's keto lifestyle to me is still critical. I just met with a young lady that I'd never seen before, but she thanked me for getting pregnant on Kiltz's keto. But she then went back to her standard diet and then had a miscarriage. So it really is critical. Keep the inflammation down by staying keto, keto, keto. All right, Twixie, you want to get that, Dr. Fink?
Let's see, Twixie is traveling from out of state. How many times do you have to travel to the clinic? You are not alone. In fact, so many of our patients come from, again, just all over the world to have their procedures done in Syracuse or in Colorado Springs.
Soon in Miami.
And soon in Miami. And since Dr. Faruqi is based out of Montreal, how often do your patients actually have to come to clinic?
Actually, much less often than they think they need to. We're talking about the clinic here in Syracuse. Because our travel team can arrange monitoring anywhere, and we use your local OBGYNs, we use your local ultrasound facilities. We get the information to us, and then we can manage your cycles. We are experts in handling cycles remotely.
So when you come to get a retrieval, how long typically are you in town?
So you come the day prior to at least. And preferably bring in a friend, a family member, a partner, which will help tremendously. And then you go home the day after the retrieval if you're doing a freeze-all of either eggs or embryos. And then you'll stay for 4 to 6 days later if you're doing a fresh transfer. But if you're close enough, you can go home and then come back.
Like the patients in Montreal, they go back maybe 2-3 hours after the retrieval. That evening, they're home.
Then traveling the day of the procedure is something that we want to be very cautious about. Again, making sure you have someone to take care of you. And if not, we will help arrange for someone to care for you the day of the procedure, and just ask about that if you can. And by the way, our Sarasota office will be building this year and will be providing IVF. Miami will be building as a monitoring center. But we are doing retrievals in Buffalo, Syracuse, Albany, and Colorado currently. And we are also working on our Atlanta monitoring center right now, being a retrieval and a transfer center later in the year for sure. And for those, Nikki Douglas asked about joining us on our global team. We are expanding our global team, and Donna is handling that. Just send your request to D. Miller. Just J. Taylor at cnyfertility.com is a good, easy approach for that. And we are growing our team. We need you as our village to grow our eggs and sperm and embryo donation, gestational carriers, making fertility and keeping fertility affordable accessible for everyone. Dr. Fink.
Well, I want to address Amber, who is stimming with us in Colorado Springs. She had 11 follicles on Wednesday, and then by Friday only had 7. What happens to those follicles? First of all, we're talking about follicles so that everyone knows, and if you're going through the process, you're familiar with the term, but those are what we call the little egg houses. It's a little space within the ovary, a little fluid-filled space that contains the oocyte, or the egg. So these we can see, and that's what gives us the knowledge of when to trigger to move towards doing that retrieval. But Dr. Faruqi, what's your thoughts on decreasing number of follicles?
Well, there's 2 things that can happen. You may have different size populations of follicle, and as the bigger follicles grow, the smaller ones become less and less obvious. That's number 1. And number 2, when you actually end up doing your retrieval, we then start counting the eggs. So not every follicle has an egg. Perhaps 85% of follicles have eggs. So it is completely normal that, let's say you started off with 15 follicles and you end up with 10 eggs or 12 eggs. There's nothing wrong with it. And at the end of the day, the embryologists look at that egg and then they strip the eggs off, sort of a cloudy haze around them called a cumulus, and they're able to tell us which eggs are actually good, and we know that the next day. So it does come down from the original number to the real number, but that is not a problem.
So even though you're seeing 11 and 7, there's still some that you're not seeing yet, and just keep on your stem, keep visualizing those follicles growing and getting a good number of eggs. But a lot of this is not numbers, it's quality over quantity. We've been talking a lot about minimal stimulation protocols are really great pretty much across the board. Higher stims may be required for some that are resistant to the drugs, the medications, the really resistant PCOS and metabolic syndromes. But I would say keep on the stem, visualizing the 8 to 12 eggs, and hopefully getting, again, a few really great embryos for that one embryo to become that beautiful baby.
Let's go over to Lauren, actually, on this side here, who is asking about ovarian drilling. She is said to have the highest AMH that some doctors have ever seen in their career. Ovarian drilling, what does that mean to you, Dr. Kiltz?
Well, I call it ovarian acupuncture, and by putting little small holes in the cysts in the ovary, which I think it has a little bit of an inflammatory reaction, it tends to improve the egg quality and release either naturally with stimulation with letrozole or Clomid, or improve the IVF stimulation. I don't worry too much about these AMH levels personally, but I do know that metabolic syndrome, PCOS, is rampant in so many young women, whether they're attempting conception or not. And the ovarian acupuncture or drilling is a simple laparoscopic procedure that if you're not conceiving with a letrozole Clomid trigger, intercourse IUI, or your eggs are not looking good at IVF, then I think the ovarian drilling acupuncture is good. Also looking for endometriosis, which is an intra-abdominal pelvic inflammation, which I see so commonly with women with polycystic ovarian syndrome. Remember, PCOS, metabolic disorder, is simply inflammation due to the wrong dietary recommendations of the modern experts of the world.
Let me add something, Rob. It's rarely a first-line treatment. In other words, you don't want to do ovarian drilling and then just as your first step. Dr. Kiltz just said, if you're not ovulating on a regular regimens, then we may consider it. There is actually a downfall in doing ovarian drilling, which is it might, repetitively at least, it could reduce your ovarian reserve too.
Yeah, but
we're destroying the ovarian cortex a little bit.
And we all agree on everything we talk about, by the way, always.
No,
again,
no,
right, we don't. And so, but I would say that because laparoscopy is often forgotten, and ovarian drilling is one of those things, oh, it doesn't work. But I've got to tell you, I've used it and I've seen it work. I don't do it repetitively. As Dr. Faruqi said, it's not good. If it doesn't work one time, you don't need to do it again. But if it worked one time and it got you where you need to go, I've done it a second time for that success again and seen it work. So
I've done the same too.
Yeah.
Hey, welcome to Kristen over on the Facebook side. When are you supposed to retrieve? So maybe people are just starting out on this journey and are wondering about, the timing of how all this works. Dr. Faruqi, talk to us about timing of retrieval.
All right, so when we start stimulating your follicles, they're tiny follicles. We call them antral follicles, and we try to recruit a whole bunch of them, and they start growing. There is no real number of how fast they grow, but average maybe 1 millimeter a day, and they get to a certain size where we now start presuming that they're becoming mature, because the eggs inside those follicles are maturing as the size increases. So then at one point we're going to decide, okay, we have the right amount of follicles, they're the right size, we want to trigger. And we give you a medication that induces that ovulation. That's what a trigger is. And typically about 35 to 36 hours later, we will go and retrieve your eggs. And I hope that answers the question.
That's a good one. Yeah. Before we get back to this side, gosh, Diane, glad to have you with us. Where do I get my antioxidants for egg quality if I'm on the keto diet?
Well, the ovarian balloon through molecular fertility, and I hope you guys can see that. Let me see if I got the right angle for that. It might be lighting, but go to our website, CNY Fertility, look at our molecular fertility supplements. We have
And
there we are.
Oh, and we're back.
Okay, sorry, we were.
Yeah, we got lost there.
Yeah, we got lost.
Sorry about that.
We're back.
Cara Regina had 3 embryos genetically tested, and you guys are not big fans of genetic testing because of a loss at 21 weeks, which is a tragedy due to a genetic problem. So one of the embryos came back what they called inconclusive. And this was just a conversation that we had with some patients just yesterday in the office. Dr. Faruqi, talk to us about what those results actually mean.
Well, first of all, I'm going to say to you that not everybody shares my opinions on PGS. Not every fertility specialist, but
PGS means pre-implantation
genetic screening, or PGT, which is pre-implantation genetic testing. Same thing. Number one, we're not testing the embryos. We're testing the cells around the embryos. And initially, when we started doing that a couple of years ago, we said,
looking for something.
Keep going, looking for embryos.
Just keep going.
So initially, when we figured this one out, we said, hey, this is the golden bullet. This is what's going to make a game changer in IVF. And we started testing almost everyone's embryos, or encouraging to test them, to come to realize, hey, wait a minute. And we do 10,000 cycles a year. Doesn't take us long to see things. How come we're getting less pregnancies? And the other centers in America started seeing the same thing, come to a conclusion that we're actually maybe we're throwing away normal embryos by calling them abnormal. And that raised alarms. People started looking. Embryos that were donated, that we thought were abnormal, we ended up testing the actual embryo, because that would destroy the embryo. But we actually tested the embryo, and lo and behold, there was a fair amount of normal embryos that we were calling abnormal. So at the end of the day, the best way to look at PGS, in my opinion, is it's a marker for your success as opposed to normal or abnormal. So if we tell you your embryo is normal, you have about a 60% chance of having a baby at home. If we tell you your embryo is a mosaic, which means some of it is normal, some of it isn't, maybe 40% chance of having a baby at home. But you don't want to throw those away, obviously. And if we tell you your embryo is really abnormal, still 15% of those embryos will be a baby.
So it's not black and white, you're saying.
Absolutely
it's not normal, abnormal. It's only really a predictor of whether that pregnancy is going to
is more likely or less likely. It's all probability. Medical science is only probability. There's no exactness to any of this. And that's one of the things. It's a grading system. You might say, gee, I'm going to use the more normal embryo first, like the more better quality as we've graded an embryo. So we have to be very, very careful about that. And a couple things I just wanted, because I got to two questions here. One is about biochemical pregnancies, and one is multiple failures with blastocyst embryos that don't stick. Ultimately, the cause of all infertility is inflammation. And we have to realize that it's either the inflammation that affects the sperm, the egg, or the embryo, or the implantation site. If what you're doing isn't working, well, don't stop, keep going, but look towards either a surrogate or changing the process that we're learning and doing in this. And I say simplify level 1 immune, or go to the level 4 where you add IVIG and Humira. So many people are missing that. So many people have missed laparoscopy, hysteroscopy, and treating with the antimicrobial antihistamine protocol or the anti-endo protocol. So there's really a host of things that through the family building guide, through Amazon, you can download that and get a paper copy, also a hard copy. There's a lot of really great stuff. But Michelle Reagan has been watching, and this is not easy to go through failure after failure after failure after failure. But the critical part is let the failures build the strength in your persistence in what you're doing. Don't ever give up. And the biochemical pregnancies are the same problem. You're getting an embryo that's beginning to stick, but your body is rejecting it. It's rejecting it because you have inflammation due to some nanoparticles that elicit inflammation. Dr. Magarelli was talking to us about that earlier today, and I think this is where acupuncture, massage, visualization, and meditation are really critical. Don't give up. Look at the kiltz's keto lifestyle, but look at all these alternatives in the process, and don't give up.
Hey, what is the, and good morning, I'm sorry, the daisy it looks like there. As far as the Sarasota office, a beautiful, beautiful town and a beautiful office space that's being crafted to care for you right now. What's the timing on that, Dr. Kiltz?
Well, sometime this year. It's not in our hands technically yet until probably April. We have some work to do. Hopefully get a monitoring center in there by June 1, and somewhere between September and December, get an IVF lab there and be able to do retrievals and transfers, be able to ship embryos from our locations to do transfers there. Again, we're working on that in Sarasota, in Atlanta, and we just opened up a Philadelphia monitoring center, so we're excited about that with Dr. Ivanova, ultrasound, blood draws, and monitoring. We're going to continue our ability to virtually do consults to share with you the thoughts and ideas to improving this whole journey for you.
You know, and I'm sorry to reach over here like this. I feel like I'm poking Instagram in the eye when I go to do this here, but was something was very worth mentioning there, and no, there we go. I'd like to say hello to the best doctor, Dr. Faruqi, and I had to point that out because guys of a certain age can't see that far, and so I just want to.
Yeah, let me add, he's the youngest one of us here.
So I can say that kind of thing, actually. Speaking about all the different places that we're doing, what kind of work do you do in Montreal, and how does CNY Fertility Montreal fit in the picture?
It fits very well, actually. We are one of the things about Canada, and not to say anything negative about Canada, it's a great country, but one of the things about Canada, particularly with IVF, is everything is sort of like the same recipe all the time. Canadian doctors aren't exactly very adventurous, and so this immune treatments and things like that are not readily available to Canadian patients. But because of CNY Fertility, we are now able to offer all these treatments, and our typical patient from Canada has actually tried IVF multiple times in Canada. They have failed, then they come here, and we have a little bit of an out-of-the-box thinking. And honestly, after having spent, how long have we been working together now, Rob? 25 years, 30 years, all these years, there really, really is a difference if we start thinking out of the box. The regular in-the-box thinking might help 60, 70% of the people, but what about all the rest? We need to have out-of-the-box way of thinking, come up with a bespoke solution to everyone's problem.
So plus the office, again, Dr. Faruqi and his team are excellent in consultations and monitoring, but we work with many of the fertility specialists in Canada to offer gender and additional out-of-the-box thoughts and ideas, especially when it comes to reproductive immunology. CNY Fertility is a reproductive immunology center, really, really critical that we recognize that immunology is the most important part of the black box, by the way. A question on weight loss and playing a part in health. My personal bias is that weight loss isn't the key, but if you're losing weight, that means you're in an anti-inflammatory environment more than anything. So the fat in our bodies doesn't cause inflammation. The sugar in the belly does, and in the bloodstream. So if you're losing weight, that means you're in a general lower glucose environment. It's a higher ketone bodies, maybe a little bit higher, but it's really an anti-inflammatory environment. So I never tell anyone to lose weight. I suggest the keto lifestyle, kiltz keto lifestyle. Again, we label it because we have books out there that I think share an idea that's radically different that'll help you in this journey. But it helps sperm by men going kiltz keto lifestyle, helps the egg and the uterine environment tremendously.
Hey, Randy, there's a good question over there about 1 or 2 embryos from Renion.
Let's see, Renion's 38, has done 2 IUIs that haven't been successful, and you're doing an IVF cycle now. On the transfer day, do you recommend transferring 1 or 2 embryos? And that is, and Mythbuster, is it really okay to eat fries? How many times have we eaten fries over this birthday weekend?
Okay.
Let's admit the truth here.
So 1 is best, but over 35 non-tested embryos, the first, second, or even the third, still 1, but you may look towards too, but it's individually defined. There's not some global answer in all this. We have to recognize medicine is very imperfect, and one way to fit everyone doesn't work. But in general, one is better, two is reasonable, and in some cases, but in my opinion, if you're eating, so keto is a high fat, low carb, low protein diet, in my opinion. If you consider proteins and carbs in a similar fashion, they both break down to sugar eventually and become fat. If you and so fries, in my opinion, is a simple sugar dipped in mayonnaise and cooked in duck grease, in my opinion, or coconut oil if you are a vegan or a vegetarian. That it's a reasonable approach. But from time to time, simple carbs are okay in my opinion, but not all the time. And for me, it's mostly carnivore, one meal a day. And I do occasionally have, we love Mirbeau fries. We love lemongrass. If you go to Mirbeau, go to lemongrass, ask for Kiltz's cut of the ribeye also.
Hey, but you know what? You mentioned something that's important there, and we've said this on some of our other lives, that you know, if you want to have a reward, it's okay. It's not cheating.
Well, reward yourself in life. But and oh boy, on my birthday said we just enjoyed cake and cookies and candy and dinosaur and a little of everything. And but I felt it later. Oh boy,
that's okay. But you were rewarded for your birthday.
Yeah.
Hey to Melissa in Montreal, who also gives a shout out to Dr. Faruqi. Man, you know, I'm starting to think that you actually might be somebody here.
Wait till I show up in Miami now.
But there's a good question here from Mimi, who has a 3 centimeter submucosal fibroid and a 2 centimeter cyst on the ovary. Does this affect fertility and IVF? And there was a question before, someone was asking about a submucosal fibroid. Fibroids are balls of muscle in the uterus. All right, the uterus is made of muscle. Its job is to squeeze the baby out when that time comes. Inside that muscle is a glandular lining that is to create a spongy, warm, juicy place for a baby to implant. So about 70% of women have fibroids. Fibroids themselves, they used to call them fibroid tumors. They are a benign growth, meaning to say they're nothing that's bad, and really are a normal variant in most people. When those fibroids get very large, they can start to have an impact. And certainly when those fibroids are within the cavity, and those are the ones that we call the submucosal fibroid, that can have an effect on the lining, which is where the baby is going to implant. And I like to think of it as taking up valuable real estate on the inside that is really better served by an embryo. So if there's something inside the cavity, we will generally recommend that you take care of that. And that is usually a pretty straightforward, easy in-out surgery that's done through the vagina, through the cervix, to remove something that's within the uterine cavity, like a submucosal fibroid.
But just like anything else, nothing is black and white in medicine. And you have fibroids that are not in the cavity, but they're in the muscle, and in my opinion, are disrupting the blood flow, or they might be doing things that we don't even understand yet. And the patients aren't getting pregnant. And we keep telling them, no, these fibroids are not affecting you. I don't believe that's true. And I've had many pregnancies, and Rob, and you have too, where we went and we removed those fibroids, and the patient showed up pregnant.
Fibroids are abnormal in the woman's uterus. They're a sign of inflammation. That's all it is. It's like fibroids. We see them commonly because everyone has inflammation. The uterus and the thyroid gland are the most common sites to see inflammation. Thyroid dysfunction is rampant, and uterine fibroids and endometriosis are too common, and they are signs of inflammation. As Dr. Fink said, they're tumors. 99% of the time, 0.9, they're not cancer. But if I see them and you're not getting pregnant and or you're miscarrying or you're failing implantation, get them out.
Yeah.
Even if they're serosal, it's a sink of inflammation. Fibroids are secreting inflammatory particles. They're robbing the blood flow. They're not normal. in my opinion. There's a significant predisposition to these inflammatory particles that happen in our bodies. In my opinion, it's due to the wrong diet and lifestyle. I think that's critical. There was a question here on the ERA, and let's see, I missed exactly what it was. I apologize for that. But the endometrial receptivity assay is a biopsy of the uterine lining at a particular time after either a trigger shot or progesterone that may help us understand the window of implantation for a frozen embryo transfer. It may help about 20% of the cases. So it isn't something we often use as a first line, but if you're doing a frozen transfer and you want to do it first line, that's up to you, and we'd be glad to add that to the process.
Over on this side, Faith Beebe, I believe it was, had a question about, well, it said she's had situations where she's had just one follicle and her local reproductive specialists will not do a retrieval. Do we do retrievals on single follicles?
You know, yesterday, Rob and we had a talk about a patient precisely with the same situation, and she called us saying, listen, our doctor is not doing a retrieval. Can you do the retrieval? And we said, come on over. And guess what? She has a baby. So we never know. We never ever know.
It is wrong to say that we know.
We don't know.
Things. Oh, you have one. We're not going to give you a judgment and say, well, that one is certainly not going to make a baby. So
we're not that smart, and I would say it's again, if you're 44. So we've had a couple of 44-year young women, by the way, and we've seen 44 young women have babies either naturally through immunology treatments, through IUI, and certainly through IVF. So if you're interested in giving yourself a chance, never ever give up. And I've seen inability to get eggs at 44, do kiltz as keto, and voila, show up pregnant naturally. So,
well, and actually, and on that subject too, a couple of other things that we talk about. We talk about Omnitrope, we talk about Serovital, and there was a question from Facebook a little while ago that we didn't get to that asked about, do you do those things simultaneously? What are they really doing? And what's the circumstance that you talk about people for those meds?
Well, the Omnitrope, HGH, Serovital, the Somaderm, there are lots of human growth hormone supplements or Western pharmaceutical grade that may help with sperm maturity production and egg maturity and production. We don't really understand the mechanisms of these things, but it may help your own natural human growth hormone to be stimulated. Human growth hormone is important in our cellular function, like thyroid hormones are. But we recommend these if maybe have quality issues or quantity issues. We also do ovarian rejuvenation, uterine and ovarian PRP treatment. There's just, again, it's a global approach to improving your chances. We do a lot of 30, 60, and 90-day priming protocols. Again, if you go to our family building guide on Amazon, you'll get a lot of really great tips. But if you just look at our Facebook, Instagram, YouTube comments and questions, we're learning, what are you doing? What did you do to get to the baby that you so desire in this life?
And it's so nice on these Facebook Lives to see the support that you give to one another. I think it's very appreciated. I certainly appreciate seeing it. It shows just really how much love we have out there, and that's a beautiful thing. There was a question from the Facebook side that was addressed to Dr. Faruqi before, and I apologize that I missed the name there. But we're talking about a lot of things pertaining to women. The question was about sperm fragmentation, DNA fragmentation, that seems to be more popular in Canada. And the question was if Dr. Faruqi why don't you tell us about some of the sperm testing and some of the male factor side, and is that testing indeed more popular in Canada?
Well, I don't know if it's popular in Canada or not, but I think it started when we started questioning cases where we were doing IVF with perfect sperm, perfect ovarian reserve, and then all of a sudden failing to produce embryos, and the fertilization rates were good, and then on day 3 everything started crashing out. So we said, listen, there's got to be more to sperm than just a sperm test, a semen analysis. And we do know that sperm has the DNA in it. So someone came up with this idea, let's see if the DNA is damaged, because we know that the sperm that we have today was produced 90 days ago. So those 90 days that the sperm is out there is exposed to inflammation, it's exposed to external toxins, environment, cosmic radiation, you name it. And that can potentially damage the DNA in the sperm. When the sperm's DNA gets damaged, it breaks, and it's called it fragments. So we started looking at what's the percentage of fragmentation in the DNA. And normal fertile males is 15% or less. And we started looking at as it starts increasing, stuff starts happening. So up to about 28, 30%. We still get really good results with IVF, IUI. When we start going past 30%, less embryos, past 40%, even more miscarriages. So it's one thing to know that, and then the next thing to do is how do we go about reducing DNA damage in the sperm? Rob, you're an expert in that.
Well, so if you're infertile, suffering miscarriages, early or late, prematurity, it's all due to inflammation. And so it's, even if everything looks normal, even if DNA fragmentation is normal, morphology is normal, don't discount the fact that there can be a sperm abnormality that we just don't know how to diagnose it. So that's why the keto lifestyle is critical for men and women, egg source, sperm source, in reducing inflammation. That's why for men, low-dose naltrexone, CBD oil. Would you hand me this over here, this box right here, Dr. Faruqi? Can you?
Antioxidants.
So this is so cool the testicles with the snowballs. The antioxidants, and this is where molecular fertility on the male and female side are critical. The omega-3 fatty acids, fish oil. We're coming out with a plant-based seaweed oil also, because and this is where the oils reduce inflammation. Keto is a high-fat diet. It's not a low-carb diet. Fat, when consumed, reduces inflammation everywhere. That's the trick of the universe. Get off the treadmill, slow it down, get out of the hot tubs. Although we enjoy them, you want to cool the testicles, cool the ovaries. And when you're exercising too much, you're heating up the core, heats up the ovaries and the testicles, and causes the damage. It's such simple stuff. We're seeing so much success on Kiltz's keto lifestyle, adding acupuncture, massage. Look at CNY Healing Arts. Look at Fertile Hope Yoga, and our new Fertile Spirit, which is also allowing us to talk. In talking, it reduces the stuff we carry on our backs, the stress and struggles. It'll help tremendously. But these are all the ways for men and women, and couples or single, whoever you are, whether you're transgender or whatever we label ourselves at, we have to recognize that the stress and struggles of life do affect inflammation. And by reducing it, it'll help us tremendously.
Over on the Instagram side, Twinsie has a blocked fallopian tube that's full of fluid. That has a term. We call that a hydrosalpinx. And the question is, should I have my tubes removed before proceeding with IVF? Well, that hydrosalpinx can be a dangerous thing to an embryo. Dr. Faruqi?
Yeah, so essentially it contains, the fluid that you're seeing contains a lot of inflammatory substances in it, cytokines and white blood cells, and essentially there's a reflux of that fluid back into the endometrial cavity. And unfortunately, the embryo shows up there and gets exposed to all these toxic substances, and it costs us implantation rate drops. So it is that's a relatively non-controversial situation. When you have hydrosalpinx, we like to remove it prior to doing a frozen or fresh embryo transfer, because definitely improves our implantation and pregnancy rates.
Well, let me ask your guys' opinion on this, because in the discussions I've had with Dr. Magarelli,
What happened there?
something hit the ground. In the discussions that we've had about removing the tube versus just putting a clamp on the tube, that some say that removing the tube can affect the blood supply. What's do you have an opinion on clamping that tube so the fluid can't flow in the uterus versus removing it?
If removal is better, because it not only removes the fluid that goes back into the uterus, if that's the case, but it also removes the source of inflammation.
Absolutely.
And so I think removing is better, but if you can't remove it, I think clamping it, transecting it, and I think a month of the antimicrobial protocol is really good.
Definitely. You know that there's also a risk of just clamping the tube, because remember, it's blocked. It's blocked at its distal end, and there's fluid in the tube. And that fluid is actually escaping through the uterine cavity. Now you're blocking it both sides. So it is not inconceivable that a couple of months from there you might have a pelvic mass, and now you're going to have a surgery to remove a 6 centimeter pelvic mass, because we block the tubes on both sides. So I'm not a big fan of blocking the tubes. However, there are certain cases where it's so difficult to remove the tube that the only solution we have is to block it to be able to do IVF. That's where I do just the clamping. What about you, Randy?
I would agree. It's in my experience, it's really the same. You know, a clamp is an easy thing to do, but if you can remove that tube, you're taking away the source of inflammation.
And to say that there is a drop in ovarian reserve, actually that's true, but it's usually a temporary drop. For a couple of weeks after the procedure, you will see drops in AMH level. What does that really mean in terms of fertility? I don't really know, but there's a little drop and then comes right back up.
If you're just joining us 47 minutes after the hour and live from Syracuse or upstate or near Syracuse, New York, Skaneateles, New York, it's Sunday house call with Dr. Kiltz, but today joined especially by, I'm Dr. Randy Fink from CNY Fertility in Colorado Springs and also in Miami, Florida, and Dr. Fayez Faruqi from CNY Fertility in Montreal and also here in Syracuse. We're so glad to have all of you with us. Boy, we just have all kinds of great questions today, and we're not able to get to all of them, but we sure want to try. If you got a question, please throw it back at us. If we missed it, we're going to see what we can do to get there.
Okay, it's Chloe. You can add double Cetrotide or add some Lupron to help reduce the risk of ovulation. There was another question about estrogen and adenomyosis.
We've had a couple of questions about adenomyosis. And why don't you tell us, for those who don't know what it is, how do you describe adenomyosis? So
adenomyosis is endometriosis, which is inflammation of the uterus. That's all it is. It really is simple. The fibroids, adeno, and endo are all ultimately an inflammatory process. Estrogen seems to be a cofactor in its development, but it may not be the cause, in my opinion. But if you have the inflammatory particles plus estrogen that affects blood flow, which is going to increase the inflammatory particles, the nanoparticles being deposited there, it can affect your fertility. Many women have very minimal adeno, many have a lot. Some will conceive and deliver naturally without a problem, like endo, like fibroids, all of that. I do recommend a 60-day medical treatment with the Orilissa Letrozole or the new treatment which is a higher dose Orilissa with a little bit of estrogen progesterone may also benefit those patients. But Kiltz's keto is really, really, really the key. And in some cases, the uterus is not repairable and it will not sustain a pregnancy, and that's where a gestational carrier may be needed.
Yeah. And it's unlike the fibroids, which we would be saying, let's go ahead and do surgery. It's a little bit different story when you have adenomyosis. I'm not 100% sure that surgery is actually a good thing with adenomyosis, because it's really difficult to remove from the uterus, and maybe we cause more harm than
good.
But
there are a few cases that you can remove an adenomyoma, which is similar to a fibroma, which are really fibrotic tissue that's either spread into the uterine muscle, which is a little harder to remove, or it just simply as a glob that's more easily removable. But they can be done. either via laparoscopy, via robot, or via a laparotomy, depending on your surgeon's expertise in any of these areas.
I think of adenomyosis. We talked about the muscle, that's the uterus, and the glandular lining, that's the inside. It's when that glandular lining starts to spread into the muscle. Much of the time it's diffuse, but sometimes it can actually form a little ball, right? And that's what
those are the ones
but
that you can remove.
It's a metaplastic. I think, I personally just look at all of this as a metaplastic inflammatory reaction to inflammatory nanoparticles. That's really what it is more than anything.
I see Heather over here on the Facebook side has a prolactinoma. Dr. Kiltz, how do you find that the little tumors in the pituitary gland, which is what a prolactinoma is, how is that going to affect someone's, how does it affect overall reproductive success?
Well, the micro and macro adenomas of the pituitary gland can affect the normal regulation of LH and FSH and secretion, which affects normal ovulation and maintenance of the corpus luteum and the progesterone, estrogen levels after ovulation in early pregnancy. So typically treatment may be simply with adding progesterone and helping with ovulation, or it may be related to adding Dostonex or Parladel to the process. But quite commonly, it's these low levels of 30 to under 100 may be treated simply with Dostonex or Parladel or the ovulation induction, but some may need microscopic removal by a neurosurgeon, but that's pretty rare.
Yeah. Oftentimes taking the medication will shrink that prolactinoma itself, but in Heather's case, her prolactin level was at 38. Is that going to impede her success with an assisted reproductive technology?
So again, the 30 to under 100 typically treated with either bromocriptine or Dostonex can be the easiest way to help with that. In assisted reproduction, we're adding progesterone and estrogen. You've either taken Clomid or Letrozole or gonadotropins to help stimulate ovulation, but supporting it with the progesterone estrogen may be all you need. But typically, I am going to recommend adding the treatment with some progesterone estrogen, maybe enough. But we want to keep an eye on that and monitor levels, but also make sure you're looking at thyroid, because when your thyroid is out of line, it can affect your prolactin levels.
They talk to each other.
And so treating them that way is really important. There was a question earlier about, hey, I'm at 50 micrograms of thyroid medication, and now my TSH has gone to 1.58. I'd hold that level, don't drop it down to 25. And then just keep an eye on watching your T3, T4, and TSH levels.
And there's another thing. A lot of people have elevated prolactin, and we don't know why. And so in medicine, we call that idiopathic. And it's not necessarily related to tumors. So if someone tells you your prolactin is high, it doesn't mean you have a tumor. And the microprolactinomas, when you get pregnant, have no effect. It's the really big ones, but they're extremely rare. We see one every 10 years, perhaps. And the reason why we remove those ones is because it compresses on your optic nerves. And then you have like visual field changes. But like I told you, those are extremely rare.
Hey, thanks over here for this great shout out from Dylan. Appreciate that, with her 15-month-old boy. So what a blessing. Glad to have you with us this morning. Yoya asks about progesterone suppositories. And yeah, they definitely can cause some irritation. They create some vaginal irritation sometimes and some cramps. Dr. Kiltz, does any of that affect implantation?
Well, inflammation, if you're bleeding and cramping, we know there's inflammation in there, and putting anything in the vagina may stimulate some inflammatory particles. Plus, all these drugs we use may have other particles in them that we're allergic to and causes inflammation. So I think we need to be cautious about that. If you're having any of these irritative effects, then I think look towards either oral progesterone, estrogen, intramuscular progesterone or estrogen, or other factors. Follow your levels really critical. It may be important to look at the antihistamine protocols, to look at the antimicrobial protocols, add an additional steroids, and kiltz's keto lifestyle is critical. We've seen so many, and we're asking people, please share your video stories, preferable, and say, hey, yeah, we can post them and share them. We have a new book coming out on keto and anti-inflammation, and we're hoping to share more and more stories to get you guys to success.
Brittany asked the question, well, how long do you need to be on keto before starting stim? And I think the right question would be as soon as you can, right? But what would you say is the minimum amount? If Brittany wanted to wait to start her stim until she at least had some chance to let keto start doing something to her body, how long does it take for a keto lifestyle to start to have an effect on your body?
So 2 to 4 weeks is all you need, and your body's going to fight it. Remember, we're addicted to carbs because carbs get us fat, which is survival. And but it's only 2 to 4 weeks you need. It's amazing how quick, by emptying the bowels of all the carbs and the low-fat stuff, in my opinion, is the best thing you could do. Again, kiltz's keto lifestyle: 1 meal, 1 snack if you need it. And I always say get a nap in there, and infinite mindful, faithful meditations a day, and add the fat. So check out our kiltz's keto lifestyle. Altamish, how are you doing? When do you think I should start acupuncture? Acupuncture, massage, meditation now, maybe weekly or every other week or monthly. You figure it out. If it feels great, do it. If it doesn't, run away. But I would say a week or 2 prior to stim or retrieval or transfer is really good.
History of breast cancer over here on the Instagram side. How do these hormones, I presume you're talking about hormones associated with IVF treatment. How do you approach the patient with a family history of breast cancer?
Well, first of all, I got to say to you that there's been a change in our thinking concerning breast cancer. So initially, we thought that estrogen was the big culprit causing breast cancer, but as we looked at that more and more, it's now becoming obvious, and this might shock a lot of people because not everybody knows this, but estrogen actually reduces your chances of breast cancer. It's no longer a controversial statement. I would even tell you that American Cancer Society website even mentions it. And even now, the oncologists are beginning to accept this idea.
Yes. To accept
yes, because you might have an oncologist that won't accept it.
Well, there are many oncologists who will say, don't even mention the words that start with the letter E in front of me, because estrogen is the data. Because many of these tumors that are estrogen receptor positive, if you block that estrogen, it results in a favorable response to those tumors. But that doesn't mean that estrogen caused the tumor. Estrogen causes breasts.
Inflammation causes all cancers, period. And so the estrogen, getting back to the adenomyosis, estrogen stimulates blood flow. Blood flow brings all that inflammation exactly to the areas that you don't want it to go to. And so that's where I bet that link really is.
And so we've been doing these treatments quite commonly since the 80s. And initially people were very worried, are our treatments causing breast cancer or ovarian cancer? So we observed over a period of years, now there's like, how many million babies now on this planet born by IVF? 5 or more than 5 million babies. Can you imagine how many cycles we had to do to get 5 million babies? And we are able to know now that those patients who delivered those babies, some of them are grandmothers, and those babies now are mothers themselves. We did not observe any increase in risk of breast cancer or ovarian cancer in the patients that had fertility treatments as opposed to general population. And when it comes to your family history of breast cancer, if it really worries you, we can do genetic testing on you, see if you have the genes. Once again, even if you have a family history of breast cancer, doesn't mean estrogen is going to cause a breast cancer. So, and I will also add, opposite to that, a lot of people who have breast cancer, in fact, the majority don't have a family history. So how much does genetics really play? It plays a small role, but the real big role is
all human beings are genetically predisposed to the cancers because we're exposing ourselves to the wrong diet. That's the single most amazing answer I've ever found.
Well, speaking of that diet, you know, one of the things that we all fall a victim to is the caffeine. And good morning to everybody. Thanks for being here with us.
Wait a minute.
Here's the giving up caffeine.
And a kiltz cup, by the way, you can get them on Etsy, and I'll be working on more of them. But do your own pottery and painting, and add crafts to your life, and slow it down, but be creative in this crazy fertility journey. Really critical.
But we talk about keto as it pertains to inflammation. Does caffeine, Josh asks, have anything to do with inflammation, and might that improve outcome?
Well, too much caffeine, like too much anything, is adversely a factor in our body. So I would say yes, it is a plant phytochemical that may adversely affect your health and wellness. But we all, we like to claim whatever we love to do is okay, but a little bit of anything may ultimately have a low dose profile, but the dose makes the poison. Is really Paracelsus came up with this in the 1500s. Too much, too often too much frequency is really the killer. So 1 or 2 cups a day may be reasonable. 3 or 4 or 5 cups a day, no way. More water, but not as much as they say. Is the thing that I recommend.
We're approaching the top of the hour here on Kiltz's Sunday house call, and boy, it's been so nice to be here with you. Let's see if we can kind of. You want to keep going?
We'll keep going a little bit more.
Can
We had a little drop down.
Can I have a question?
Lay it on us.
Okay, Randy's a specialist in hormones, and I want to ask him, even for myself, as all of us, tell me, what does stress do to our hormones?
Well,
and why is it bad?
Stress has a huge effect on our hormones. People ask me about stress all the time, and yeah, it would be lovely to say, well, just take the stress out of your life. But if you can figure out how to do that, I'd like to have some time spent with you, because I want to be able to mimic that.
Me too.
Yeah, right. I think that's a big one. But stress affects our cortisol levels. Our cortisol is our body's stress hormone. It's the thing that mediates the response, our body's response to stress. It causes cortisol causes us typically to start to deposit fat along here, because it is a ready source of energy to try to burn off, because what we want is fat for energy.
That is the only energy of our body, survival.
So, and once that cortisol axis, it's called the hypothalamic pituitary axis and our adrenal axis, once that starts to get affected by stress, everything starts to change with it. Cortisol levels go up, our testosterone levels go down, which makes us not feel so well. Estrogen and progesterone in women especially starts to fluctuate. So that's why, as healthy a lifestyle as you can, start every day with a positive thought. Can you just actually repeat your mantra?
Well, this is a great book, The 3 Magic Words by U.S. Anderson, and I would just recommend everyone read it. For me, stress, without it we die. We must have some stress. What you want to use is the stress in your benefit. And so that's where spirituality and faith in a higher power comes into this process of health and wellness. So if you can use the challenges in your life to your benefit, bingo. The
stress is like sailing. It's the wind, and you need to become a sailor to use the wind to move forward. Don't let the wind capsize your boat. You need to become a sailor and trim your sails in consequence.
And that's the power of
beautiful.
I just made it up.
Our great philosopher, Dr. Faruqi, is a great friend, and we're a family, by the way. It's really critical that we all recognize that we are all on an equal level as human beings. When we learn to treat each other as the gods within each and every one of us, that's so important. We as physicians are learning ideas and thoughts that we can help you, but you bring thoughts and ideas that we don't even understand. And we want to all be doing that together. And so thank you, God, for this awesome, amazing day. And without the challenges, we wouldn't grow and learn and be better. All of us have lived through many, many challenges and many, many more to come. And God is the great love of our universe. And the more we can expand that idea, and this is where the 3 magic words come in. When you read it, you'll be like, oh my God, this is crazy amazing. But if you haven't read my book, The Fertile Secret, and I'm sure you've all read The Secret by Rhonda Byrne, but the secret is God is within all of us. Whether you believe in God or not, that's the absolute truth of life. And thank you to everyone, by the way, for the shout outs and all the thoughts. And thank you to my good friend, Dr. Fink, Dr. Faruqi. And I'm learning from my good friends, and we're all learning together as a family, the CNY nation, of crazy ideas, by the way. But if we don't blow up what we think we know and be open to these really different ideas. Dr. Vida, by the way, brought PRP to us, ovarian rejuvenation. She's even finding that by adding a little PRP to the testicles, we may be able to rejuvenate the testicles. So we need to be open to such amazing, crazy ideas.
Amber says, you 3 together, an adorable mess. Adorable mess.
Okay, thank you there.
Clearly,
And
clearly that's what you meant.
Donna Matt, thank you for my teddy bear, and to everyone's shout outs. I just thank you to all of you guys. But remember, we need to be shouting out and helping everyone. We've had some losses, and this is a sad, hard, frustrating, depressing journey. When we're hearing the anger, the sadness, the frustration, we all need to share the love that we want to bring to everyone in this really crazy, stressful, hard mess. And that's why it's so critical. Daily prayer and meditation. I do my daily inspirations, and I'm reading from my daily intentions, inspirations book. Check it out on Amazon also, but write your own. Remember, put the picture on your wall of your newborn babies that are coming, your family that you're building, the life things that you're expanding. And I can tell you that we all need to be sharing these things together.
Every moment, every breath is another opportunity, Reki. Thank you very much for sharing that. And that's a good one. Do you want to take a few more questions?
Oh, I'll keep going.
We have the time. We have the time. Thanks again so much for being here with us. Let's just say again, we've got Dr. Kiltz. I'm Dr. Randy Fink and Dr. Fayez Faruqi. So happy to have you with us here on this beautiful Sunday morning. I think it was Amanda had a setback with her last pregnancy. She developed a DVT, so that's a blood clot in the leg,
caused
by inflammation. So a blood clot. So she was on bed rest, which is really the #1 risk factor. It's immobility in pregnancy, where all the with the hormones and the body's increased ability to clot. So it's not an uncommon thing to happen. But would that change your approach to her, if particularly with regard to estrogen, if she were going to do treatment now?
Well, I don't believe the estrogen is the cause. The birth control pill may be, but because it's a plant particle, and actually plant lectins cause phytohemagglutination. And my bet is, again, it's dietary nanoparticles that cause the blood clots, damaging the glycocalyx. Look it up, you'll be amazed. But we would add aspirin, prednisone, and Lovenox, and make sure that that's a critical part to the story. And Kiltz's keto lifestyle. I know I'm a broken, crazy record, but I absolutely would recommend that.
And by the way, the estrogen that you levels that you achieve during the treatments is nowhere as close to the estrogen levels you're going to achieve when you're pregnant. So the treatment is probably not your biggest fear. It's when you actually become pregnant and you have all these high levels of estrogen and progesterone. But even then, with the prophylactic treatments and things like that, I don't see it as a problem.
Now, many people who are pregnant who have a history of having a blood clot may be maintained on a medication to help prevent the blood from clotting during the pregnancy. But as far as treatment goes, I think you're okay. Bird Bash, so glad to have you with us. Femara or Clomid, so letrozole or Clomid added to a retrieval, added to a stim cycle. Guys, why do you want to do that?
Yeah, because it works.
What's it doing?
So it's doing a combination of things. It's helping the brain put out some LH and FSH that's going to also assist in stimulating your eggs. But it also has a modification, the endometrial lining, that helps with implantation, whether you're doing a fresh cycle. And it just modifies the system to help improve ovulation and implantation. So why use it? Because we've found that it works well. I personally recommend it in a mini protocol. Again, when we say mini protocol, I'm saying 10 of letrozole for 5 days, 200 of gomorrhafolostim, and 20 of HCG, adding the 2.5 milligrams to the estrogen in a frozen cycle also helps tremendously. Why? We don't always know, but we just know that as fancy chefs, these are some formulas that we have found work tremendously.
Actually, most of the stuff we use, we don't know why it works. We just know it works.
One of the comments to this is that Clomid tends to have more adverse side effects than Femara. We also use Femara and letrozole for guys in 2.5 milligrams, along with low-dose HCG at 250. Ask about it if you're not on it. It can be helpful for the guys also. And we are male fertility experts at CNY Fertility. So we can help you along your way. And if you need a surgical correction of a vasectomy reversal or a biopsy, we have the team to help you do that.
Let's see. I can't see. It looks like Ziganet says, can I carry twins after a myomectomy? Yes. Yes, you can.
Not the best idea though, right?
Well, it just depends, you know. It depends on how long after the myomectomy. Some people had a myomectomy 10 years ago and are pregnant now with spontaneous twins. It has to do with the mode of delivery, how big the myoma was, and whether it impacted the cavity of the uterus,
or how close it is to the lining. My bias, I do a lot of laparoscopic myomectomies, in that if it's 2/3 through the myometrium, definitely it's going to have a bigger factor than if it's just a third through the myometrium on the serosal side. But I would say that the correct answer is a singleton is better. Twins are more risky. You're just going to have to make sure you probably deliver a little bit earlier, or be prepared to do that with any signs of early labor.
Nicole asked, what is PRP? So PRP is platelet-rich plasma. And there was a couple of questions we had before, actually, I think on both sides here, about using PRP in the ovary, which I think is a fantastic thing to try. Dr. Kiltz, tell us about, well, first of all, let's say, what is PRP?
Platelet-rich plasma is basically extracting your blood, spinning it down, collecting the serum, and then spinning it again and trying to get the really smaller component of the platelet-rich plasma section, which contains a lot of anti-inflammatory particles and stem cell particles that may help rejuvenate the testicle or the sperm or the ovary and the eggs, or it may help rejuvenate the uterine lining. But it's used on the skin, in other organs, in joints, in many other ways. And on the fertility side, we're finding that can be helpful for thickening the uterine lining or improving implantation, even if you have a good lining thickness. That's one of the things that we have to be cognizant of. Hey, my lining is great. I don't need PRP. My team, PRP, HCG wash, and Neupogen washes all will help with implantation.
There was a question over here about, is anybody in Colorado embryology today? And embryology works every single day. They may be hard to reach, and I don't know about how much communication comes out on Sundays, but bear in mind also that Colorado is in the midst of a major winter storm, which is why I'm still in Syracuse today, because my flight got canceled going back to Colorado, and we'll be back tomorrow. But
And our embryology teams are amazing at every location. We're training more embryologists, but they're focused on your egg, your sperm, your embryos, and doing the work. They're not there to answer every call and get to every message in the day. It may take a few days, but if there's any reason they need to reach out to you and give you some information, they're absolutely going to do that. But I apologize, but they're focused right there, and we're going to do our very best to get you more and more.
And like Sundays, we have limited staff. They just come in and check out the embryos, because they're there seven days a week.
Well, they're doing
365 a year.
They're doing biopsies and freezings and checking your fertilization. So they're absolutely there doing all the work.
Trish is with us today on the Facebook side. Glad to have you with us. Hi there. Question is, can you talk about the difference? Dr. Kiltz talked a minute ago about mini IVF, but compare and contrast a regular or a standard IVF cycle with a mini cycle.
Well, I mean, it's the initial thought was think big, which basically the mantra was, let's get the maximum amount of eggs that we can possibly get, because then we can play the numbers game, get more embryos, more chances. So it does work for younger patients, but then again, mini protocol works too. What happened was that patients who had low ovarian reserve, we were giving them these high dosages of medication, sometimes as much as 600, 900 gonal-F. Those companies were laughing with the income they were getting out of that. But the patients were getting 1, 2, 3 follicles, and we're not getting pregnant. So a couple of years ago, it's actually the Japanese came up with this idea that since we cannot get more follicles from our patient who has low ovarian reserve, how about we get better quality follicles? So now it wasn't more, it was more quality. And they said, let's give minimal stimulation and see what happens. The idea being that if we give less drugs, we're going to get the most sensitive, the best quality follicles to appear, as opposed to showing that we are desperate and anyone appears. And that idea actually somewhat changed our practice. And it took a couple of years, and recently we've had studies that have come out that actually, as a matter of fact, now it's even in the guidelines of American Society of Reproductive Medicine. So it's like now in the box thinking that it's equivalent pregnancy rates with much less medication.
And Dr. Kiltz feels very strongly about many protocols.
Yeah, less is best, and we do a lot of natural cycles. We do a lot of low dose cycles, I think, are the sweet spot for almost everyone. The ones that are hardest sometimes are the resistant PCOs that need the higher doses. I do not look at your weight, your AMH. I always start low. And that is really critical, because we can save you money on the lower protocols. And tell your nursing team, Dr. Kiltz suggests a low dose protocol. And even to remind some of our physicians, low dose protocol, mini is really the mastery that I've learned. It helps so many. It sometimes makes more eggs than you even think. So it's the thing that I've focused on. We're here to save you money also, but not, and we don't want to waste your money. If you need a high dose, we'll get it for you. But if you did a low and you did better on high, we'll absolutely do that. But we're really spreading our wings in this, and our global protocols are easier.
To answer your question, Amber, yes, I would not miss your retrieval on Tuesday. I'll see you then.
And Dr. Fink's doing awesome and amazing on retrievals and transfers. We're really excited to be part of the team in Colorado. We're excited about opening up our Miami satellite for monitoring and consults. But our consults are strictly global and virtual today. We're going to continue those. And we're grateful for Dr. Fink joining our team.
Hales over there on the Instagram side is asking about ovulation. So it looks like she was on birth control for a couple of years and then stopped the birth control, or was on birth control and then stopped, actually, I think a couple of years ago, and may not be ovulating. What makes somebody ovulate or not?
Well, nature and the integrative system within the body through the hormones and other mechanisms create ovulation for fertility. If you're not ovulating, you're not getting pregnant, you have some inflammatory process going on, and we use medications when it's not working naturally, or it's not working with dietary changes and anti-inflammatory acupuncture massage. This is where we go to letrozole, Femara, Clomid as our first line, or add the gonadotropins to stimulate that. And why some people ovulate easier than others, we don't really know. I always say, if what you're doing isn't working, be open to do something else. The why, I don't ask why. I say, what is a new way? And let's get on the way and let's just do it, and not spend all of our time on why. My mother didn't like me asking that question.
You got in trouble
all the time.
Right, and he's still in trouble all the time. Let's talk about endometriosis, because it's such a common thing. It's a recurrent theme through here. What is endometriosis?
Actually, we don't know.
We know it's
inflammation. Well, that is obvious. But what?
Not
how? There was this guy in the 20s. His name is Sampson, who came up with the theory of endometriosis. To this day, is the prime theory that we are teaching our medical students. Nothing has changed in our understanding of endometriosis since the 20s, except that it's an inflammatory process, and it does affect fertility, implantation, and so on and so forth. And actually, it's way more common than it's thought.
So here, my theory is it's an intra-bowel disorder. Bowel inflammation in the pelvis causes inflammatory changes in and around the ovaries, uterus. But endometriosis is actually a systemic disorder. It's a very common, younger and younger and younger. And so I think if we just look towards bowel inflammation, we'll actually solve the problem. But most of us are kind of a little bit narrow-minded. Again, all of us are that way. Open up. But if you reduce the inflammation in the bowels, you'll reduce the inflammation in the pelvis, you'll reduce endometriosis.
So I have a thought, and I'm just going to ask you guys. When we were medical students, way back when, we were taught that endometriosis is really a disease of the women in their 40s, and then we started seeing endometriosis in younger and younger patients. I have 12-year-old patients with endometriosis. Is it because we became more enlightened, or is there more endometriosis that we're beginning to see this?
Well, I believe, once again, our dietary practices are showing us that diabetes and cancer and hypertension, PCOS, metabolic disorder, fibroids, we're seeing more and more fibroids younger, endo younger. So again, we're looking
also
for
breast cancer, huh?
All of it. All disorders are on the rise. The cost of healthcare is on the rise. And if you simply look at the Western culture over thousands of years, we are killing ourselves with absolutely the incorrect advice. And when we recognize, again, it's the intermittently feasting, 1 meal a day or less. I know it sounds hard, but you're worth the most amazing changes ever created in the universe. These ideas are radical, but they're so simple.
So endometriosis is when that lining of the uterus that normally sloughs out at the time of a period appears to implant in sites inside the body, most commonly inside the abdominal cavity and the surface that's called the peritoneum. It can implant in the ovary and on the uterus. And yes, in fact, it can move to other parts of the body. I've seen it in the lung before. I've seen it in the liver, in the nose, certainly on the skin. It can absolutely happen. We had someone who has a 2-centimeter endometrioma, which is a collection of old blood in one of the ovaries. How does that endometrioma affect her cycling, or rather affect her IVF?
Well, it may not. Endometriosis, endometritis, or adenomyosis, or uterine fibroids, they're all inflammation. Many women conceive and deliver babies with this inflammation, so why does someone else not? Again, it's the mystery. But if you're not, the endometrioma, if you're not getting good eggs, good embryos in a pregnancy, then it may be reasonable to treat it laparoscopically by incising it and draining it. You need to be careful about removing the cyst, because that's where you begin to diminish the ovarian reserve, and you have to be very careful about that. I really believe that it's simply a metaplastic changes due to localized or systemic inflammation that is the cause. Again, we have our theories, we don't know, but I would say inflammation is the sine qua non one that makes the most sense in everything.
And hopefully that answered your question there, Peter, as well. And that, can laparoscopy to treat and diagnose endometriosis.
But let me just we'll finish one thing, because we treat both medically and surgically. So this is where the at least 60 days of medical treatment with either Orilissa or Lupron and letrozole 5 milligrams has been shown to have a nearly equal effect as the surgical approach. So if you're saying, gee, I don't want to do the surgical approach, do the medical approach. If you're open to the surgical approach, which is typically for surgeons, we go to the knife before we go to the pill, another option.
So that was exactly what I was going to point out, that I tend to look at endometriosis more as a medical disease as opposed to a surgical disease. But when you do,
which is a change, a change
that's
from the way
a change that we're
has
thinking.
approached this
Yes.
for the last 50 years.
The other thing, and I want to have your thoughts on that too. Not every gynecologist is a very good reproductive surgeon. And we see stories where young women had an endometrioma removed, showing up with incredibly low ovarian reserve. So when you do need surgery, I think you need to look out and try to find a physician that has experience and cognizant of the effect of these surgeries on your reproduction. Not every surgeon is really good at removing fibroids. Not every surgeon is really good at treating endometriosis surgically in the infertile patient, which is different than gynecology.
Jane says, I lowered my dose for her retrieval. She's 42 and got 13 eggs. That's fantastic.
Yeah.
We don't know if we don't try.
Do or do not, there be no try. It's a doing. If what you're doing isn't working, guess what? Change it up.
And I will bet you, Jane, that you could have gone to other places who would have said, you're 42, you're not going to get anything, so we're just not going to do it.
Yeah.
All right. Do you recommend keto diet for endometriosis? Remember, endo is a inflammatory disorder like everything else, and always go to what you put in the mind and the mouth first. And keto is for everyone. It's a lifestyle for life, not a 30 days, let me get pregnant. But kiltz's keto lifestyle, in my opinion, is a life experience. It's so amazing. You'll feel better. Now that I've turned 95, it's just like amazing what it's done for me. 65.
He doesn't look a day over 94. I'm just saying. Yeah, right.
He said yesterday that he's going to say to everyone he's 95, so he gets used to it. So people think he's
So
young.
when I'm 95, it'll be, then I'm 115. It'll be like amazing. Grandmother lived 105, or actually 104.
Is there a relationship between endometriosis and low ovarian reserve?
Well, inflammation causes endometriosis, endometritis, fibroids, and it damages the ovaries, which causes diminished ovarian reserve, which can be turned around by keto, LDN, CBD, PRP, Omnitrope. So if you've been told, oh my God, your reserve is dead, forget it. Don't believe them, but look towards our keto lifestyle, look towards our family building guide. You'll find a lot of really great advice, but just listen to so many of you guys out there. Thank you for sharing your stories. It's really critical because we're all built on stories.
Hey, Sherilyn asks a good question, and because we didn't really address too much the uterine lining today, sometimes we get a lot of questions about that. She's about to do her frozen transfer, the double layers or the trilaminar. Tell us what that stuff means.
Well, the triple layer is generally telling us that you have a more a normal lining that we like. So it has the 3 lines of the center between the 2 anterior and posterior layers of the uterine lining, or it's homogeneous and we can't see that. The homogeneous may mean, there might be a polyp or a fibroid there, but it is also a normal finding that we've seen plenty of pregnancies with. So typically we're saying, gee, the triple lining may be better. If you're not there, let's do some anti-inflammatory protocols. Let's do the antihistamine protocol. It may mean a hysteroscopy DNC, a laparoscopy, PRP, Neupogen washes, and let's, even some cyclic estrogen progesterone months, which allows your lining to grow and then slough and grow and slough, along with acupuncture. Thanks to Don Clark, by the way, CMI Fertility leader in acupuncture, been with us for 20 years. Thank you to Don in Syracuse. Appreciate everything you've done.
Let's see here, and I just saw one there. After a hysteroscopic lysis of adhesion. So some people get scar tissue within the uterus. We can go in with a little camera and an instrument and try to make that cavity more normal. How long after a hysteroscopic procedure like that would you recommend a patient wait before transferring an embryo?
Well, it depends on the severity of it's called Asherman syndrome, by the way. So it depends on the severity of the Asherman syndrome. If you have a situation where there was scar tissue, you went in hysteroscopically and you took it all out, and right away the cavity looks normal, I wouldn't wait necessarily very long, perhaps just to recoup from the surgery and start trying to do a frozen transfer or a fresh transfer. If you had severe Asherman syndrome, a grade 3 Asherman syndrome, for instance, sometimes you might even require multiple surgeries to be able to get to a point where we can even start thinking of doing a transfer. So the way that goes is we do a surgery, wait a little bit, we go back again, we take out a little bit more. So 2 steps front, 1 step backwards, 2 steps front, 1 step backwards, slowly, we get to a point where now we're beginning to see a cavity. Then that cavity has to be populated by endometrial cells. PRP is a really good way of doing that. Even just sitting there and waiting, and what you just said a minute ago, giving estrogen, progesterone, you're basically stimulating those stem cells to differentiate to endometrial cells that then start creating the cavity. So in those cases, time is actually on your side.
Cowgirl Yeehaw. I just like the name, right? I just like the name. You're 40 years old. Your AMH. Young.
40 years young. Right. It's the word.
That's correct.
Yeah.
That's absolutely my fault there. Yeah, forgive me for that.
He's getting old because he's getting old. He's getting old.
Right. Yeah. Your AMH is 0.14, and you're doing 3 cycles of mini IVF. Thoughts?
Well, just go right to our family building guide. A lot on that. But always imagine you have beautiful eggs, you're going to make a beautiful embryo and get a beautiful baby. And this is where the PRP comes in, the LDN, the omnitrope, the human growth hormone comes in. And I do dual or triple stems with a mini protocol with human growth, I think is really important. 10-220 HGH6, do a retrieval 4 to 7 days later, do the next stem, the same protocol, even if you get no eggs. And at least 3 times, because I've seen the generations improve. Most of all, Kiltz's keto lifestyle is critical. Go to Amazon, download the book, get a paper copy. We have a new one coming. Excited about that. Oh, don't forget Miss Maria Emmerich. Whether you're doing carnivore or other ketos, she does carnivore. She does some other stuff. We love Maria. She really has some great stuff. She shared many of her great recipes on there. So go over to Maria's stuff and give her a shout out from Dr. Kiltz, Dr. Fink, and Dr. Faruqi, and the Fertile Fireside Chat.
Just beyond 30 minutes after the hour, we've been with you for this morning. Yeah, we've been here for a while. And let's just say it's as we start to wrap up here, I want to say it's so nice to see really all the love coming from so many people and so many different places, not just directed at us, of course we don't mind it, but to each other, and the help and support that you can give to each other. And this is really a fabulous thing. At CNY Fertility, we're really all about you and all about making your dreams come true. And God bless you all for being with us and for letting us be a part of your world. Dr. Faruqi from CNY Fertility in Montreal, let me just say also what a treat and what a pleasure and a real honor it is to be with these 2 superstars.
Crazy
Superstars. Dr. Faruqi, closing words?
Honestly, our true inspiration comes from our patients. We wouldn't be able to do what we're doing if it wasn't for the inspiration that comes from reading all these messages. I would say to you, it's the purpose of my life to be able to help all my patients build families. It's the greatest thing we can do. It gives a purpose to our lives. And it will give a purpose to the moms and dads that are coming here.
And so thank you for joining us, Dr. Faruqi, Dr. Fink, and to everyone out there. I'm really appreciative. The Fertile Fireside Chat every Sunday. Dr. Verdialis, Dr. Magarelli, Don Clark, Jennifer Waters, Elizabeth Lee, Ali Santoro, and to our whole global and CNY fertility teams and everyone out there. Keep sharing the thoughts and ideas, helping us make this a better journey. And we honor all the gynecologists, all the fertility doctors, everyone out there on the naturopathic and osteopathic and chiropractic side, that we're all really working together and we're learning together. So thank you very much. We'll see you guys, Dr. Fink and I, maybe Thursday afternoons at 4 Eastern time.
Don't miss it.
And back on Sunday. So God bless you guys. We'll see you then.
Have a great day. Thanks
Take care,
for being
everyone.
with us.
God bless.